So we don't have a case today because I wanted to make sure that Spencer had all the time that she needed. Dr. Moorman is a doctor of social worker and a licensed clinical social worker. She is at Norton Children's Hospital Research Institute, where she serves as a research scientist, and she is working to integrate evidence-based psychosocial practices into the clinical environment. She's a PI on several studies that are really aimed at improving the psychologic standard of care, as well as implementation and prioritization for both sickle cell and pediatric cancer. She serves as the advocacy chair for the Kentucky Pediatric Research Trust Fund. And who knew, Spencer, that you played senior pro pickleball nationwide on the APP tour? So hold your pickleball questions till the end, everyone. But from there, I'm going to turn it over to you.
Thank you. Thank you so much. It's great to be here, and I always appreciate the opportunity to speak to medical providers about psychosocial care. So thank you for the opportunity. And I'll get going. So today's objectives are review the elements of psychosocial care and the roles needed to execute the biopsychosocial health model. Reveal findings of a NASAC-supported benchmark study aimed at understanding the current psychosocial roles, infrastructures, and provider perspectives that exist across sickle cell centers, and assess lessons learned from NASAC psychosocial providers in the identification of gaps for future efforts to enhance psychosocial care in sickle cell disease, and ultimately establish sickle cell disease specific psychosocial standards of care.
Excuse me, we can't see your slides. If you don't mind sharing your screen with us.
Oh my gosh. That would help. Okay. Thanks, Sonia.
There you go. And that's fine, or you can put it in presentation mode.
Is it in presentation mode?
We can see your next slide. So what you want to do, if you go back, if you go back to it and go to display settings at the top, you can click on presentation mode.
Okay, I've got slideshow.
So if you go up to the top where it says display settings, click on that. And then, oh, you have two monitors. Try that. There you go. Perfect.
Are we good?
We're good.
Okay. Sorry about that, y'all. Okay. All right. So we already been through the objectives, and now want to start about talking about the biopsychosocial model of health. And the ultimate goal of psychosocial care is to help individuals have a sense of control and meaning in their lives, enhance their quality of life, and improve their overall mental health and well-being. Our patients as human beings are complex, they're multi-layered. And so the biopsychosocial model of health is a model often referred to in the literature. It's also endorsed by ASH. But we as psychosocial providers also have the spiritual, sexual, cultural lens added to that, to incorporate the complexities involved in each individual's story, and their history, including the spiritual, cultural, sexual aspects of things as well, and their individual blueprint. So all of these variables contribute to the overall well-being, and you can see how it takes an army to help support individuals with many layers. And so here are some of the psychosocial roles that we have in sickle cell. Some rarely exist, from what we found that I'll talk about a project that we've done. But here is a general overview of the psychosocial roles that exist across other diseases as well. So coming from the lens of social work, each psychosocial role is incredibly important, but the role of social work comes from a social determinants of health lens. And so we look at the person in the environment, and we come at care from a social justice, health equity perspective, where our values are dignity and worth of the person, human relationships, competence, integrity, and service. And so social work is unique in that way, that we've always tried to incorporate the person and the environment when caring for the individual. Now, from a social work perspective, there are strengths of social work, but there are also some challenges in terms of role identity and roles within the role. There are lots of different licensures, training, education when it comes to social work. And so a lot of times this can be confusing amongst the psychosocial care teams, as social workers can wear many hats. And here you see, you know, for instance, at one point in time, I kind of starred all the different roles that I felt I was playing while a full-time social worker for all of the diagnoses on the pediatric side. And so it kind of spans lots of different psychosocial roles in that sense. And so I want to talk to you about a project that we did. The inspiration for this project came about at the 2022 NASAC Alliance conference in Hollywood by the beach. We were striving to create psychosocial standards of care in sickle cell, and we were thinking about what consensus guidelines we were going to recommend. But at first we were like, well, we really need to understand what supports and infrastructures exist first to be able to even go forward in terms of where do we even begin in recommending some consensus guidelines. So, as you all know, and the literature states, sickle cell comes with many challenges, including depression, anxiety, substance abuse, higher risk of academic and job challenges, the social and systemic health inequities, stigmatized care, unequal access to care, lack of funding and prioritization. And in the literature, when it comes to psychosocial care on the medical side, what we found is social workers are the primary provider of mental health services in the US as of now. The roles continue to be poorly understood within the healthcare system. And while the literature includes info about social work roles in the cancer realm, many are not based on data that are collected directly from the social workers themselves or psychosocial providers, but from social work educators and administrators instead. And so few studies have actually collected data directly from psychosocial providers. And so we said, well, nothing exists right now in the literature about the psychosocial infrastructure on a macro scale in sickle cell disease. We know anecdotally what it looks like, but we wanted to gather some concrete data to really represent what it looks like. And so our research questions and objectives were, what psychosocial roles, infrastructures, and insights exist across sickle cell teams and centers. And we sought to look at the demographic and work-related characteristics of our psychosocial providers. What are the barriers that they are dealing with and experiencing? do they know what the funding source is for their roles across centers nationwide? What do their caseloads look like? And what are their training protocols? And what are their insights and perspectives about what could better help them help our patients? So we did a cross-sectional mixed method survey, and we sent it out to NASAC centers, asking them to give it to their psychosocial providers. We actually got 83 responses, which we thought was pretty remarkable in the psychosocial realm and in sickle cell disease, especially. So we asked some closed-ended items and we asked some open-ended items. We collected the survey in REDCap, and we used univariate analysis and SPSS to get down to the nitty-gritty of the results. So here is what we found. The following slides show green being the highest answer, yellow is in the middle, and red is the lowest. And so you can see that, not shockingly, most were female respondents, 92%. Only a third were African American, with 2/3 being white. And there was a high level of master's degree, doctorate degree respondents. And the most respondents fell into the working in sickle cell disease only from 0 to 2 years. So we can see that there is a high turnover in the psychosocial realm. So when we look at respondents and the breakdown, we had 48% of social workers answered, 16% of psychologists, and 34% were other. You can see the breakdown here of what those roles look like. Not represented was art therapy, nutrition, music therapy, financial counselor, community-based organization member, and we didn't have any patient advocates or volunteers. So in terms of embeddedness in sickle cell, who worked full-time, part-time, you can see that social work was divided about equal full-time and part-time, and as well as 51% of social workers worked primarily in the pediatric realm, 41% worked mostly with adults. You can see that's different for psychology. 87% work part-time in sickle cell, with only one psychologist working primarily on the adult side. 93% of psychologists in the sample work in pediatrics, representing a gap that we know of in care for the adult population. No full-time psychologists dedicated to strictly sickle cell were represented either in pediatrics or adult. So across the board, most psychosocial providers exist in the pediatric space, despite the ever increasing patient needs and longevity of life on the adult side. When we asked what other diseases do the providers work in, you can see that for social work, hemophilia and only social work were tied. For psychology, most of them worked also with cancer patients or bone marrow transplant patients. And for our other category, it was strictly sickle cell disease. When we talk about what roles exist or what roles you have access to at your center, we ask the respondents to say, did this role exist? Is it part-time, full-time, accessible, or do you refer out for the service? And so here are the results for that. The top 3 roles that are lacking in pediatrics are disease education, a patient navigator, and transition coordinator, with art therapy, music therapy, and disease education lacking on the adult side. Between just social work realms and psychology, most respondents at adult centers recognize social work and clinical social work as being present, whereas in peds, it was psychology and clinical social work. Only 12% of ped providers identified neuropsych as non-existent, yet 37% of adult providers surveyed identified neuropsych as not existing at their facility. When it comes down to top 2 focuses of psychosocial roles, you can see the breakdown here, where social work said their number 1 focus was financial assistance, followed by counseling and therapy, and then community outreach. Psychology, understandably counseling therapy first, followed by grants and research. And third, or last, was administrative. We asked them about their training prep in sickle cell disease, and 51% of respondents said they had some training. 48% said they did not. Were they educated about stigmatizing language? 38% said they disagreed, that they were not, and educated about disparities in funding across diseases. 37% agreed that they had been, but 28% disagreed they had not been educated about the disparities. When it comes to titles of particularly social work supervisors and who do they report to, we found that 50% of social work respondents actually report to a social work manager, whereas 30% report to a clinic manager and 20% report to a medical director or a physician or division chief. One interesting finding was asking psychosocial providers if they were part of a comprehensive sickle cell center. When we put it in those terms, of social workers, 65% said yes. But when we asked social workers if they were members of a NASAC center, only 43% said yes. And so you can see the disparities there with understanding whether they belong to actually a NASAC center. So psychologists, same thing. 86% said yes, we are part of a comprehensive center, but only 40% of them said yes when it came to a National Alliance of Sickle Cell Center. When it comes to provider perspectives of their roles at sickle cell centers, we asked them, are you a member of a national organization for your discipline? When you look at social work versus psychology, 86% of psychologists that responded said they were a member, where when it comes to social workers, only 20% said yes. So they do not have a designated sickle cell disease specific support network to belong to on the social work side. They all agreed that it is important to have that kind of networking and support in order to improve patient care. But when it came to satisfaction level with patient needs being met, you can see that the top answer across social work and psychology was neutral. And what came in second was very unsatisfied. with patient needs being met, where satisfied and very satisfied came in last. When we talk about asking them to report on their caseloads and what do those look like, this is amongst social workers only. You can see just by this one slide the variance in what they reported. So on the left, you can see if a center had 600 to 800 patients, 400 to 599, you can see the different sizes of centers on the left. And then you can see some of the responses, one being I see 300 plus patients, one being I see 192. From the centers between 200 and 400, we got several 150s. But just looking at this slide, you can see like the disparity between what a case is amongst a social worker, and of course what a case looks like across the different licensures and roles of a social worker. So this was definitely a topic that we've talked about and we've needed some more clarity about. But the results that we got shows that we need to do a lot more digging into this matter to really quantify exactly what is a case, what does it involve, and try to differentiate between the different roles of a social worker in terms of what role they're playing in their center. To the best of your knowledge, is your role a revenue generator? Can your services be billed for? Out of the 74 that answered this particular question, 36% said yes, their role was a revenue generator. Of those 27 that answered yes, to the best of your knowledge, are you actually billing for your services since your role is a revenue generator? Whereas 77% said yes and 18.5% said no. One respondent was unsure. When we asked about overall participant barriers to care, in their opinion, the top three were funding for psychosocial positions, lack of psychosocial staff, and time to provide psychosocial care. We asked them several qualitative questions, and I'll just share a few with you all. In hindsight, what would have better prepared you to work with patients in the sickle cell domain? Most of the answers were around either they needed more disease knowledge. For instance, yes, specifically related to medical terminology, specific to the disease, better understanding of the disease process. I wish that I had more knowledge or access to trainings about sickle cell in general and resources specifically for our patients. Understanding treatment options, care needs, and impacts of the organs, the body from sickle cell disease. And then there were several answers around the explicit and systemic racism in sickle cell disease, a better understanding of the history and the bias toward the healthcare system and across medical teams, more awareness to the systemic racism that these patients face, along with the environmental factors that affect their healing, and how to combat racism perpetuated by other healthcare providers, knowledge about systemic racism impact on health and healthcare decisions. And then another theme was shadowing and networking would have been really helpful. Wish I would have had the opportunity to connect with some other social workers in the field or having some kind of orientation, shadowing other centers, networking with other social workers before having started their role. what would be most helpful for medical providers to keep in mind from the psychosocial provider perspective. And the three themes were role understanding, remembering that an LCSW is a mental health provider, which means they can provide evidence-based therapeutic interventions in the moment and not just there for financial assistance. Remembering that physicians are not behavioral health providers. So please stop giving unhelpful and sometimes damaging advice. Or sickle cell disease medical providers must remember that the primary goal of the psychosocial provider is not to just achieve adherence or compliance, but to empower patients and families to live their best lives. And importance of psychosocial care was another theme. Support and encouragement of patients to embrace psychosocial services would be helpful. To please advocate for it and prioritize it. And please give the psychosocial providers time with patients. And then really understanding the patients, having to meet them where they are. And although we as a team may have an idea that may be beneficial to their psychosocial needs, the patient is the expert for themselves and has to be willing and ready for the help. And then I believe a large part of these situations is due to healthcare providers not understanding the culturally different communication styles and behavioral reactions as a trauma response. We asked them what would be most helpful to your psychosocial practice. More psychosocial team members, having a comprehensive support team and system in place. To have psychiatry and psychology services more readily available, a dedicated psychologist who has an interest in working with sickle cell disease individuals, a certified cognitive behavioral therapist, additional employees to provide wraparound assistance, service to patients and families. Also opportunities for networking and institutional support to practice at full licensure, support in billing and coding and scheduling, more discussions and changes at the institutional level when it comes to the care and treatment of patients with sickle cell, networking with other sickle cell disease centers and being invited to national sickle cell conferences, and then protected time for patient care, additional time to work therapeutically with this population, more structure in the workflow and getting assessments scheduled, allowing me to be a full-time in hematology and not scattered about other diseases, more clinic time, having time to research and implement evidence-based practices that will empower and support sickle cell patients. And there are many more quotes and examples where those come from. And so I've just shared some of what we found through this survey, which did really produce a lot of information, a lot of which we already know anecdotally and working in the space, but it was definitely some legitimizing data to go along with our experience. This is a benchmark study gathering insights directly from psychosocial providers in the field. We did learn that despite the disease being lifelong, there is definitely more support for children than for adults, which we already knew, but from these respondents, we learned more so about the skeleton structure that exists on the adult side compared to the pediatric side. And although it is a disease that affects primarily African Americans, only a third of psychosocial providers are Black. And this is something that we have talked about in our social work education, social work schools, strategies of trying to support and encourage African Americans to get into the psychosocial space. Only some of the limitations were that only psychosocial providers in the NASAC database were invited. And it's unknown as to whether all the centers were represented. We just asked them to state which region they were from. A strength was that the sample size was different for each question. So that really did reinforce the voluntary nature of this study and allowing them to answer the questions that they wanted to answer, or that they were able to answer. Some implications and next steps that we talked about it at the NASAC meeting as well were now being able to really take this information and establish a psychosocial organization specifically in Sickle and social work for the networking, education, resource exchange, and support of others in the space, and really creating a mentorship network. And then in terms of education, next steps, really continuing to try to educate about the psychosocial roles, differences, and clarifying roles across teams and across centers. Still trying to enhance our training in sickle cell psychosocial care. We've definitely moved the needle and come a long way, and just to continue going in that direction. We did learn that awareness amongst team members, a lot of us that are very involved in this space are a part of the National Alliance of Sickle Cell Centers. We're aware of what it is and what it means. We did learn that there are several psychosocial providers that know that they're a part of a comprehensive center, but they're not sure that they're a part of NASAC. And so there's work there that can be done. And then in terms of practice and policy, we can use this information to hopefully help develop some more specific psychosocial standards of care. And now that we have more of an idea of what the staffing and infrastructure landscape looks like, and hopefully be able to use this information for some advocacy in terms of grant funding for more psychosocial supports, and efforts towards advocacy in terms of getting these services to be able to be reimbursable. So I think I've touched upon several of these. We know, all of us know that the demands far outweigh the supply in terms of the staffing that we have, and especially the embedded providers that are 100% full-time in sickle cell. We have many psychosocial providers that we're borrowing from other spaces. And we did, a lot of the qualitative responses did echo the need for more support and help to better care for patients. And so hopefully this snapshot of today's psychosocial landscape can definitely lay a foundation for next steps in terms of psychosocial guidelines and advocacy. And I believe that that is it.
Awesome. Thank you so much. Does anybody have any questions? And has this been published? I know you've submitted it.
There is a white paper, so to speak, from our first year that's been submitted, and now this is being written up as we speak in many different forms for more submissions to get out there as soon as we can.
Excellent. All right. Well, thanks everyone so much for joining us. We will plan to see you all in 2 weeks and hope you have a wonderful rest of your week.